Is my screen visible?
Yes, Nikhil, your screen is visible. You're good to go.
Just give me 1 minute. Yeah, perfect. Great. So are we good to go?
Yes.
Yeah. So good evening, one and all. I welcome all of you to the session on Innovations in Hematology webinar series, where each month we discuss regarding one clinical topic, quite controversial or difficult to manage clinical cases, with a renowned expert in the field. With this webinar, what we hope to address is something that is beyond guidelines and what we face in our clinical practice on a day-to-day basis, and some of which doesn't have clear-cut answers as far as strict guidelines are concerned. So these are challenging clinical scenarios we all face in our day-to-day practice. So today we have Dr. Priyanka Pufali with us, who's a renowned expert in the field of lymphoma and has several publications to her credit in this field. Management of DLBCL becomes complicated, especially if there is a synchronous or a secondary CNS involvement. And there is conflicting data whether we need to give prophylaxis for high-risk patients, what should be the right treatment approach, when should radiation be brought into the picture, is there a role for novel therapies like immunotherapy and CAR-T? So a lot of unanswered questions. And very often once patients relapse in the CNS, despite all best efforts, the disease progresses unrelentlessly, and we have lost numerous patients to these complications. So today we have Dr. Priyanka Pufali with us, who is the assistant professor in the Department of Hematology and Medical Oncology at the University of Wisconsin-Madison. Dr. Priyanka is a faculty member in the Department of Hematology. She is a clinical researcher with a focus on clinical studies aimed at lymphoma and cancer survivorship. She was awarded the Lymphoma Clinical Research Mentoring Program Scholar Award from the Lymphoma Research Foundation. She is a member of numerous professional organizations, including the ASCO, American Society of Hematology, CIBMTR, and ASTCT. Her clinical interest includes Hodgkin and non-Hodgkin's lymphoma, bone marrow transplant, and cellular therapy. So this is our team at Fortis Institute of Blood Disorders, where we have 4 adult and 5 pediatric hemato-oncologists, along with a geneticist, nutritionist, and a huge team of nurse practitioners and critical care specialists, where we do more than 200 to 250 transplants in a year. Of late, with advent of CAR-T, we have done more than 8 to 10 CAR-T cell therapies, and we would love to hear from Dr. Priyanka what would be her take on doing a CAR-T cell therapy for a patient with CNS disease, because we have one such patient lined up and we have been debating of late the utility of CAR-T in a CNS relapse. So without taking up much time, I would like to stop sharing my screen and I invite Dr. Priyanka to take over and deliver the lecture.
Can you see my screen?
Yes, your screen is visible.
Let's put this in slideshow. Is that good?
I think you've put it on the presenter view. If you could put it on a full slideshow.
About
Yeah,
that.
perfect.
Okay. Wonderful. So thank you so much to the Fortis Hematology Group for this invitation to present. Management of diffuse large B-cell lymphoma with secondary CNS involvement is not just a challenge for you, it's a challenge for everybody. And we're actually talking about this as a group here within University of Wisconsin, Carbone Cancer Center's lymphoma group to try and decide if there can be a uniform strategy. What has happened so far is every patient comes in with a unique case scenario, and we've had to to develop a new novel approach or use a different regimen, and we haven't had any uniformity in terms of how we approach these patients, just because most of the time it's such a difficult situation. So these are my disclosures. I will be talking about off-label drug use, since CAR T cell therapy and novel agents don't really have a label for use in CNS lymphoma or DLBCL, or DLBCL involving the CNS lymphoma. So we'll talk about what secondary CNS lymphoma means and consider the three classic case scenarios. One where secondary CNS lymphoma is diagnosed concurrently at the time of initial diagnosis of DLBCL, or you can have just an isolated CNS relapse of DLBCL after they've completed frontline treatment. And then the very hard situation when patients have concurrent CNS and systemic relapse of DLBCL. Given my understanding of what the question was, I am not going to cover details about primary CNS lymphoma, but I'm happy to take any questions about that as well. So what is secondary CNS lymphoma? When lymphoma spreads to the CNS or the central nervous system simultaneously with a new diagnosis, or at the time or time during treatment or at relapse of systemic lymphoma, then that's called a secondary CNS lymphoma, which means that the CNS lymphoma can be isolated in the CNS or with concurrent systemic involvement. DLBCL accounts for the majority, with an incidence of secondary CNS lymphoma in about 4 to 6% of cases. But of course, we know that Burkitt lymphoma and high-grade B-cell lymphoma have a much higher incidence of CNS involvement and more rare involvement of CNS with diseases such as mantle cell or the indolent lymphomas. Secondary CNS lymphoma usually occurs at first relapse, which occurs early, within 1 year from diagnosis, and the median time recorded in multiple studies is about 5 months after initial treatment. Parenchymal disease does occur more commonly than leptomeningeal disease when it comes to diffuse large B-cell lymphoma in the CNS. But the rarity as well as the frequent exclusion of these patients in clinical trial limits what data we have to guide optimal management of these patients. So I'm going to go through this using some cases that I have in clinic. And as I was thinking about it this morning, I realized that the cases I chose are the ones that I have treated more recently, so I don't have long follow-up on them. But also that's because in the past, I feel like with limited treatment options, our patients did not do well, and we have lost a lot of patients to CNS relapse of DLBCL. So this first case is a 57-year-old female who presented with worsening abdominal pain. CT scan showed bulky abdominal and retroperitoneal adenopathy, which measured 9.2 centimeter on her PET scan. The biopsy showed diffuse large B-cell lymphoma, which was double expressor, non-GCB subtype, MYC rearrangement negative by FISH, and it was TP53 positive by IHC. Now, TP53 is not routinely done as a part of workup for diffuse large B-cell lymphoma, but there are multiple reports suggesting that it has bad outcomes similar to all other histologies and cancers that have TP53 mutations. This patient's Ki67 index was also very high, and her CNS IPI calculated out to be 3, which is intermediate risk. Given the high-risk features of bulky disease, double expressor, non-GCB, P53 positive, and poor performance status as well at the time of presentation, her oncologist chose to treat her with dose-adjusted EPOCH-R, which she completed 6 cycles, and she received intrathecal methotrexate for prophylaxis that is a part of the dose-adjusted EPOCH regimen. She achieved a complete remission. So let's start by talking about diffuse large B-cell lymphoma very briefly as an introduction. It is a malignancy of the mature B cells, which can occur de novo versus a transformation from underlying indolent lymphomas. Established risk factors include age, EBV infection, immunodeficiency, immunosuppression, and onset is generally acute with rapidly progressive adenopathy. 30% B symptoms present at diagnosis, 60% present with advanced stage disease. Bone marrow involvement can occur in 30% of cases, and extraneural involvement, when present, is commonly involving the GI tract. The diagnosis is established by excision versus core needle biopsy, along with the classic immunohistochemical markers that are shown here, which indicate a B-cell malignancy. Flow cytometry is also helpful, and FISH to rule out high-grade B-cell lymphoma with MYC and BCL2 gene rearrangements is now standard. Stains such as BCL2, BCL6, and MUM1 are also important from the Hans algorithm standpoint to classify and categorize the DLBCL as germinal center or non-germinal center type. Ki67 is often reported, but I don't know that we make clinical decisions often based on that. Staging is completed with a PET-CT, which is standard, and PET-CTs are now sensitive enough to pick up bone marrow involvements. And so bone marrow biopsies are generally not required for staging advanced stage disease, but are used for limited stage disease, especially if you are trying to abbreviate treatment. For patients who have a high CNS IPI, CNS staging is important, and we're going to cover that in a little more detail. And pre-treatment patients are recommended to get echocardiograms to assess cardiac function, rule out other viral infections, and fertility preservation is always an important consideration for younger patients. So the CNS IPI, which I mentioned in the case, is a prognostic tool that combines the International Prognostic Index, which has the factors of age older than 60, ECOG performance status of 2 or more, elevated LDH, extranodal sites of disease more than one, and advanced stage disease, with the additional factor of kidney or adrenal involvement. And based on the CNS IPI score calculation, this graph here on the right shows that it helps prognosticate individuals diagnosed with DLBCL into low risk of CNS relapse if their score is 0 to 1, where their risk of CNS involvement is going to be less than 1%. 2 to 3 score on the CNS IPI is intermediate risk, which means the risk of relapse is about 3 to 4%. And a CNS IPI score of 4 to 6 is considered high risk, with the relapse risk increasing to 10 to 12%. And our patient that we discussed had intermediate CNS IPI score. So the question that was posed, and that has been going around for the last couple of years, is the role of CNS prophylaxis in frontline treatment of diffuse large B-cell lymphoma. And that's because CNS relapse is associated with a poor prognosis, with median overall survival reported out at around 5 months. And the overall risk of CNS relapse, when you look at all comers of diffuse large B-cell lymphoma, is about 5%, and maybe even lower, about 2 to 3% in the rituximab era. But the standard frontline regimens that are R-CHOP, dose-adjusted EPOCH-R, if you're not using the intrathecal chemotherapy, do not have good CNS penetration or CNS active agents, which are generally the ones that cross the blood-brain barrier, such as high-dose methotrexate, ifosfamide, cytarabine, thiotepa. And so the question has always been, can we prevent this from occurring in the first place? And so as a practice, we had started using high-dose methotrexate or intrathecal methotrexate or cytarabine as prevention of CNS relapse with the frontline treatment in high-risk cases. When we do use this, the current data supports using it more at the end of treatment rather than intercalated, meaning giving mid-cycle high-dose methotrexate between day 3 to 5 of an R-CHOP cycle is probably not recommended, because there have been delays in the R-CHOP cycles because of complications of high-dose methotrexate, and that has shown to be detrimental in terms of overall prognosis for the patient. And so the current approach for us, if we want to use CNS prophylaxis in high-risk cases or cases that make us uncomfortable, is to add it at the end of 6 cycles of R-CHOP or dose-adjusted EPOCH. And generally, we prefer the high-dose methotrexate compared to intrathecal, given its parenchymal penetration. There have also been in the last few years multiple large retrospective studies that have shown no difference in the risk of CNS relapse with CNS prophylaxis, which is why our approach to using CNS prophylaxis more broadly has gone down. And I honestly have not used it in the last few years for any patients, except maybe in some special circumstances, like if they have high-grade B-cell lymphoma or disease that is anatomically very close to the CNS. So this is from the ASH education program in 2022, and I think this summarizes really our approach to how we handle CNS staging and prophylaxis at diagnosis. And this may be a little hard to read, but for any new patient with a diagnosis of DLBCL, we calculate their CNS IPI. If they have a high CNS IPI score of 4 to 6, or have more than 3 extranodal sites of disease, or a high-risk extranodal site, such as testicular, renal, adrenal, or breast involvement, then we assess their CNS thoroughly with the MRI of the head or spine and a CSF with flow cytometry for analysis. And since you are working on circulating tumor DNA, there were reports at ASH a couple years ago looking at circulating tumor DNA being a more sensitive marker than CSF flow cytometry for detecting CNS disease, but this hasn't yet translated into clinical practice and is not available in many places, including mine. When the CNS assessment is positive, then you treat the patient as a secondary CNS lymphoma. If they don't have any high-risk features, then they don't even need the CNS staging, and you continue systemic therapy with no CNS prophylaxis. And if the CNS staging is negative, then most of the time we can treat them with systemic therapy without CNS prophylaxis. However, if they do have these high-risk sites of involvement or things that make you worried about them, then the recommendation is to complete the 6 cycles of therapy with end-of-treatment assessment with a PET scan, and only if the patient is in a complete metabolic response and is fit to receive high-dose methotrexate in terms of age, organ function, and tolerability of treatment so far, then you can consider 2 cycles of high-dose methotrexate, which is defined as more than 3 grams per meter square. But in any other circumstance, we don't typically use CNS prophylaxis anymore. What about when you do find CNS involvement at diagnosis? At that time, our standard of care has been this regimen of MR-CHOP, which is mid-cycle methotrexate with R-CHOP given with every cycle of treatment. This is based on some studies in primary CNS lymphoma, which are not very large. This is a pilot study that reported giving high-dose methotrexate, rituximab, and prednisone on day 1 with CHOP on day 3. And for patients who achieved a complete remission, they were taken to an autologous stem cell transplant, versus older individuals received 2 additional doses of high-dose methotrexate after completing initial 6 cycles. This study showed an overall response rate of 100% and very high CR rate of 86%, and toxicity was mostly hematologic. There have been, however, retrospective studies of this practice of using intercalated methotrexate with R-CHOP for secondary CNS lymphoma at diagnosis, and the largest study comes from the LISA or LOC network, which includes 60 patients who had a concomitant systemic and CNS involvement at diagnosis. Majority of the patients were treated with anthracycline-based treatments such as R-CHOP, and 74% for prophylaxis used high-dose methotrexate. 19 out of these 60 patients went on to receive a consolidative autologous stem cell transplant with thiotepacarmastine conditioning. The overall response rate just after induction was 76%, with 3-year PFS of 42% in these patients. And for younger patients who went on to receive autologous stem cell transplant, both the progression-free and overall survival were improved. And this is why we approach secondary CNS lymphoma patients with this MR-CHOP regimen and always consider an autologous stem cell transplant if they are candidates for transplant. Going back to our case, who had achieved a complete remission after dose-adjusted EPOCH-R and had received intrathecal CNS prophylaxis, 18 months later, she presented to the ER with severe headaches and nausea. Her CT scan and MRI are shown here on the right, and it showed a large right frontal lobe mass measuring up to 4.9 centimeter, along with several other enhancing lesions, vasogenic edema, and midline shift. She underwent a right frontal craniotomy and tumor resection, which confirmed that this was relapse of her DLBCL non-GCB type, and she was started immediately on steroids and seizure prophylaxis. PET-CT did not show any evidence of systemic disease. Her lumbar puncture was negative by flow cytometry, and she started treatment with a primary CNS lymphoma style regimen, MTR, which is high-dose methotrexate, temozolomide, and rituximab, completed 4 cycles, achieved a CR, got a consolidative transplant with thiotepacarmastine conditioning, and remained in a CR after. So in terms of workup, patients often can present with CNS involvement and CNS-related symptoms that direct you to assess the CNS. But like we discussed, for patients who may have subclinical CNS involvement, calculating their CNS IPI and staging them with an MRI and lumbar puncture is important. Patients can also have concurrent systemic symptoms and systemic involvement. In terms of diagnosis, MRI is the gold standard, as CT scans are not able to delineate masses within the central nervous system with more accuracy. And also the pattern on the MRI imaging might be suggestive of CNS involvement with lymphoma if the area cannot be adequately reached by biopsy in terms of neurosurgical approaches. A PET CT is still important to complete staging. If the patient presents with CNS symptoms, we still want to make sure that there is or is not concurrent CNS involvement. CSF analysis that we discussed. And then tissue biopsy is important. I struggled with treating patients empirically for CNS lymphoma because many times we've been surprised when we actually do get the tissue. It turns out to be a primary brain tumor like glioblastoma or some other histology that would not have needed high-dose methotrexate. And so whenever possible, it's very important to sometimes have to push your neurosurgeons to get the biopsy to confirm that it is indeed relapsed lymphoma, or if a patient is presenting with CNS symptoms, then even more important to get that tissue biopsy. Unless, of course, the CSF is positive, which gives you a good idea. Testicular ultrasound is still recommended for males presenting with CNS lymphoma because it is a sanctuary site and assessment on a PET scan has not been known to be sensitive. Eye examination to rule out vitreoretinal involvement is also important because we have seen cases of asynchronous involvement of the CNS and vitreoretina, and sometimes we need to complement high-dose methotrexate treatment with intraocular methotrexate treatment if the response is not adequate in both the compartments. And then spine MRI with contrast should be considered for patients who present with symptoms that are indicative of potential spinal involvement. So our patient presented with isolated secondary CNS lymphoma relapse without evidence of systemic disease. And this typically occurs within the first few months of completing frontline therapy, which suggests subclinical disease at diagnosis. And that is why the emphasis has now shifted from the prophylaxis strategy to more complete CNS staging at diagnosis for patients who may meet the high-risk criteria. Our management approach in these cases is similar to primary CNS lymphoma. Using high-dose methotrexate-based therapies, our patient received MTR, but other options include RMPV, which includes methotrexate, procarbazine, vincristine, or the matrix regimen, which we're going to cover in some more detail. These regimens have demonstrated high efficacy in primary CNS lymphoma with CR rates exceeding 60%, and especially patients who undergo a consolidation with autologous stem cell transplant, these remissions have shown to be durable. In secondary CNS lymphoma, this management approach has less data. The largest study involves 30 patients who received methotrexate-based induction chemo and carmastine thiotepa autotransplant, but their 2-year time to treatment failure was 58%, which is pretty good for this challenging situation. So for managing secondary CNS lymphoma, I think the biggest study that we need to be aware of is this IEL SG42 trial with the Marietta regimen, which is the largest phase 2 international study for secondary CNS lymphoma. This included 77 patients with secondary CNS lymphoma, including 43% who were newly diagnosed and the rest were relapsed. And this regimen is shown here on the right, where patients received 3 courses of matrix, which is high-dose methotrexate, cytarabine, thiotepa, rituximab, followed by 3 courses of R-ICE, or rituximab, ifosfamide, carboplatin, and etoposide. And patients who were in a complete remission went on to receive a thiotepa-based autologous stem cell transplant. After matrix rice regimen, the overall response rate was 65% with CR rates of 40%, and 1-year progression-free survival with this regimen for all patients was about 60%, and patients who received an autologous stem cell transplant had 100% progression-free survival at 1 year. Toxicity with this regimen is mostly hematologic, and it is very important to know that there was 5% treatment-related mortality predominantly associated with infection and sepsis. This study was also able to give us some insight in terms of secondary CNS lymphoma prognosis. And what this figure here is showing is the progression-free survival for patients who had systemic and CNS involvement at diagnosis, which is the solid black line on top. And patients who had isolated CNS recurrence, which is our patient, which is the line in the middle. And the patients who seem to do the worse is the patients with both CNS and systemic recurrence who have a fairly poor progression-free survival of about 20% at 2 years. I would ask you to look at this article, which was a How I Treat Secondary CNS Lymphoma published in Blood in 2023. And it has a great summary of all the clinical trials in DLBCL with secondary CNS lymphoma. I only talked about the Marietta study because it is the largest body of evidence that is prospectively collected in this space versus other regimens that are used are not mainstream and had very small number of patients. For patients who have high-grade B-cell lymphoma, I point you to number 5, where we do use the modified McGrath regimen or Codox-M-IVAC, which also has good CNS penetrating agents and can be used for patients who have simultaneous involvement of the CNS at diagnosis. Newer studies have looked at BTK inhibitors such as ibrutinib in combination with high-dose methotrexate, as well as the TEDI-R regimen, which we will also be discussing. So now our patient had undergone an thiotepa-based autologous stem cell transplant, had achieved a complete remission, but then 12 months later, she presented again to the ER with confusion and memory issues. Her MRI brain showed increased nodular enhancement along the resection site, which was suggestive of recurrent lymphoma. And this time her CSF was suspicious for lymphoma, so we did not pursue a biopsy, and her clinical history was consistent with recurrence of her CNS lymphoma. We did assess her again with a PET scan, and again, there was no evidence of systemic disease. And so she started on a BTK inhibitor, zanubrutinib, and MRI done 6 weeks after start of treatment showed a mixed response. Because this was relapse of DLBCL that had progressed after an autologous stem cell transplant, we were able to get approval for CAR-T lisocabtagene maraleucel in the third-line setting. She did okay with grade 1 CRS and ICANS, but did have recurrent UTIs in the many months following her CAR-T cell therapy, which we mitigated through IVIG treatment. Her response at day 30, her PET scan did not show any evidence of systemic disease, and MRI of the brain did show a CR, and which is now maintained at 6 months, and we will see how durable that response is. So just summarizing some of the novel agents that we reach out for when we have relapse disease after autologous stem cell transplant, lenalidomide and rituximab has data in secondary CNS lymphoma with CR rates of about 33%, as well as some data in primary CNS lymphoma with CR rates of 35%. But the progression-free survival is less than 6 months, limited to about 4 months in many of these reports. BTK inhibitors, ibrutinib and zanubrutinib, have activity in both primary and secondary CNS lymphoma, and response rates are high, more than 67%. However, durability with single-agent ibrutinib was also shown to be limited to less than 6 months, and zanubrutinib data is still maturing. The TEDI-R regimen was a very exciting regimen, which combined a lot of different CNS active agents such as temozolomide, etoposide, liposomal doxorubicin, dexamethasone, ibrutinib, and rituximab. And this was a response-adapted approach where they started off with giving ibrutinib for 2 weeks, and then depending on response, they would be escalated to this regimen versus not. And this had shown a pretty good results, particularly in those with CD10 negative tumors with 1-year progression-free survival of about 50%. However, with the combination of high-dose dexamethasone and ibrutinib, this study saw a lot of aspergillus infection in the CNS, which is why this regimen has not become mainstream and is being modified with lower doses of steroids and lower doses of other agents to improve its tolerability and decrease the risk of infection. When it comes to CAR T for secondary CNS lymphoma, the data is limited because the secondary CNS involvement was excluded from the pivotal studies for axi-cell and Tissa-cell Zuma-1 and Juliet. However, after CAR T approval, there have been small case series both with axi-cell and Tissa-cell in secondary and primary CNS lymphoma that have shown good response rates that are comparable to systemic DLBCL with not a significantly higher risk of neurotoxicity, which was the initial concern with CAR T use. Lysocell studies did allow enrollment of secondary CNS lymphoma, but both their third-line and second-line studies enrolled very few secondary CNS lymphoma patients to draw any meaningful conclusions. But there have been a number of retrospective analyses looking at all CAR T products and secondary CNS involvement, which have shown that there isn't much difference in terms of response rates, which have been up to 50% at 12 months with axi-cell with CNS involvement of DLBCL, and progression-free survival rates are also good at the 1-year time point. Neurotoxicity CRS rates have not been shown to be excessively high, and so we have been using more and more CAR T cell therapy, particularly in secondary CNS lymphoma, where we're able to get access as for commercial CAR T. This table, again, borrowed from the How I Treat article in Blood in 2023, summarizes the studies from CAR T and secondary CNS lymphoma. And as you can see in the third column here, the numbers are very low. The largest study is only of 17 patients, but more importantly, toxicity was not any different, and overall response rate ranges from about 50 to 80%. What about allogeneic stem cell transplant? If you don't have access to CAR T, we have very limited data that is published about allogeneic stem cell transplant for secondary CNS lymphoma. The largest is a retrospective analysis of 20 cases, which reported a median progression-free survival of 8 years, which is good, but the 4-year non-relapse mortality in this report was high at 30%, and so that is not something we have been using in practice, especially with access to novel agents in CAR T. So to summarize what we've covered, management of secondary CNS lymphoma involves high-dose methotrexate-based regimens. Whether we treat with high-dose methotrexate-based regimen like primary CNS lymphoma with MTR or MBVP depends on whether the patient has concurrent systemic disease or not. But in any case, these patients, once they achieve a response, should be considered for a thiotepa-based autologous stem cell transplant. And in cases where there is systemic involvement or refractory disease, CAR T cell must be considered. Now I'm going to present a second case, which had concurrent systemic and secondary CNS involvement, which was a very challenging one in my practice. And I'm going to go through this as an example of how complicated these scenarios can be. So this is a 53-year-old female who presented with fatigue and cytopenias. Hemoglobin was noted to be 6. And because of that, she underwent a bone marrow biopsy, which diagnosed diffuse large B-cell lymphoma, non-GCB type, MYC rearrangement negative by FISH. Her PET scan shown here showed extensive involvement of multiple lymph nodes areas in addition to her bone marrow, and she started treatment with R-CHOP in a hurry, did not get a chance to stage her CNS, but she did not have CNS symptoms at the time of presentation. Her interim PET scan after 3 cycles of R-CHOP actually showed a very good response, and so R-CHOP was continued for 6 cycles. However, end of treatment PET scan showed some new adenopathy with SUV max that was high at 25, concerning for refractory large B-cell lymphoma, even though her bone marrow biopsy was negative. While we were arranging to biopsy these lymph nodes to make sure they were not reactive and arrange for a CAR T consultation, within that 1 month, she presented to the ER with confusion. Her CT scan showed this large 3-centimeter left frontal lobe mass, and you have the MRI picture shown on the right, associated with vasogenic edema. The lumbar puncture was positive by flow cytometry for DLBCL, and we also were able to biopsy the lymph node in the pelvis, which showed refractory diffuse large B-cell lymphoma. So given her predominant symptoms were from the CNS, we started her on high-dose methotrexate and collected her soon after for CAR T-cell manufacturing. We then escalated her treatment to R-MBVP, hoping that the addition of carmustine and etoposide would provide some systemic control in addition to treating her CNS disease. Excuse me. The response after RMBVP showed that her MRI brain had improved, as you can see here, but her PET, unfortunately, was showing evidence of new sites of disease and progression. So then she underwent CAR T-cell therapy with lysocell complicated by grade 1 CRS ×2. Thankfully, no additional neurotoxicity was noted. And response at day 30 post-CAR T showed a systemic disease control with a PET scan showing Dovel score of 1, but her MRI did not show any additional improvement, and the MRI brain was read as stable. So given her active CNS disease, even though her symptoms were greatly improved, we started her on BTK inhibitor ibrutinib, hoping to continue to get response in the CNS compartment. Post-CAR T, we assessed with repeat imaging at day 90, and her PET scan unfortunately now showed progression. However, her MRI was showing a complete response and remission with the ibrutinib. So then in this situation of post-CAR T refractory systemic disease, we went on to treat her with bispecific antibody glofitamab. But since we don't have much data or experience with bispecific antibodies in CNS control, we did not want to lose the response that we had achieved in the CNS. And so we continued her on ibrutinib with this glofitamab. Thankfully, after 2 cycles of glofitamab, both her PET scan as well as her MRI continue to show a remission, and we are hopeful that this is going to be maintained. So to summarize what we talked about today, we talked about secondary CNS involvement by diffuse large B-cell lymphoma, which can be de novo at the time of diagnosis, isolated after treatment of systemic disease, or concomitant CNS and systemic relapse. In all of these cases, it is important to assess patients' performance status, comorbidities, neurologic status, consider steroids and high-dose methotrexate with or without rituximab if those neurologic presentation is very acute, and clinical trials, if available, are always encouraged. It is important to realize that these cases are challenging, and the ones I showed you are examples of good outcomes, but many patients have been lost to this disease, and so best supportive care is always a consideration if you are not optimistic about disease control. For de novo presence of secondary CNS lymphoma, the data supports use of Metrix rice, but practice supports use of high-dose methotrexate with intermittently with R-CHOP. But other regimens such as Codox M-IVAC should be considered, particularly if high-risk, high-grade disease. For isolated CNS lymphoma, isolated CNS relapse of systemic lymphoma, we use a primary CNS lymphoma style approach with high-dose methotrexate-based regimens. Metrix rice also has data in this space, and consider them for consolidation with thiotepa-based autologous stem cell transplant. CNS plus systemic relapse is the most challenging to treat, and even though Matrix rice can be used, followed by a thiotepa-based auto, most of my recent patients have not successfully been taken to auto and are moving more towards CAR T-cell treatment. And if patients have relapsed refractory disease despite autologous stem cell transplant or despite CAR T, then our regimen of choice has been BTK inhibitor, typically zanubrutinib, but lenalidomide is also a consideration. And then radiation is also something we have used when we are out of options, along with best supportive care. So to summarize, secondary CNS lymphoma is extremely challenging to treat and still has a poor prognosis, although with the currently available novel agents, we are able to achieve some degree of control in today's day and age. It is important to stage the CNS at diagnosis of systemic DLBCL lymphoma, especially when they have a high CNS IPI, so that we can catch the secondary CNS involvement and treat it adequately upfront. And these patients are shown to have a better prognosis with secondary CNS lymphoma compared to if they relapse in the CNS later. Most data does not support the use of CNS prophylaxis in DLBCL frontline, and if considering it, please consider doing it after completing systemic treatment for 6 cycles and achieving a CR. And relapse DLBCL with concurrent systemic and secondary CNS involvement certainly is the most challenging and has the worst prognosis. CNS penetrating chemotherapy with methotrexate-based regimens, followed by thiotepa, carmustine, autologous stem cell transplant can provide durable responses, and that is what we try to achieve when possible. But if chemorefractory, then considering novel agents such as BTK inhibitors versus CAR T is useful. However, the durability of responses remains to be determined. And with that, I will close and take any questions.
Thank you, Dr. Priyanka. That was an excellent presentation, and you covered such a complex clinical case scenarios, and you explained every possible scenario where we would have either an isolated CNS relapse or a synchronous CNS disease in DLBCL. And I'm very sure the audience, as well as all of us listening to it, there was a lot of clarity in the way you explained the treatment options and your approach in these difficult group of patients. We have a few questions that we have collected from the audience, and anyone who has joined in, please feel free to ask questions in the chat box as well. So I'll start off with a very basic question. Apart from the CNS IPI, which you very elegantly demonstrated is a very valid tool for assessing the risk of CNS involvement, are there any other novel markers which predict the risk of CNS involvement, either from a lymphoma, NGS, or from a genetic perspective?
Yeah, that's a great question. So I think it is important for DLBCL diagnosis that we complete the hematopathologic workup, which includes the FISH study looking for MYC gene rearrangements, BCL2 gene rearrangements, because there is evidence showing that high-grade B-cell lymphoma with MYC BCL2 gene rearrangement certainly has a higher risk of relapse in the CNS. And most of the times we try to treat those patients with more than R-CHOP. So like dose-adjusted EPOCH-R, which includes intrathecal methotrexate prophylaxis. Burkitt lymphoma, of course, if that's what we end up diagnosing, even though initially you thought the patient had DLBCL, has a very high risk of CNS involvement, up to 20 to 30% at diagnosis and 50% at the time of relapse. And so in those cases, certainly CNS-directed treatment is very, very important, and you have to have a very high degree of suspicion to evaluate CNS involvement. Besides that, I think there have been some smaller case series and reports about things like CD5 positive DLBCL having a higher risk of CNS relapse. We talked about the sites such as testicular, breast, even reports about uterine and ovarian DLBCL involvement with increased risk of CNS relapse. But I think it is challenging because that's not standard for us to think about in DLBCL treatment frontline. But I think there's certainly situations where the patient presentation, clinicians get worried about CNS involvement. And I think we have to trust our gut sometimes and consider CNS prophylaxis in those cases. But I think what all the data has shown so far is systemic disease control is the most important thing, and the highest risk of CNS relapse is when the systemic disease is inadequately controlled, and that is why the move from using the intercalated prophylaxis to trying to do it at the end of treatment. Besides that, I think like we were discussing, ctDNA is exciting, and we went from doing cytology in the flow cytometry, cytology in the CSF to using flow cytometry in the CSF as a more sensitive marker for detecting lymphoma. And ctDNA is probably going to be even more sensitive as a molecular test to detect CNS involvement. And if we start doing that upfront for all our patients with DLBCL, we'll probably pick up a lot more secondary CNS involvement that's occult or asymptomatic with that approach. However, like I said, it's not available mainstream yet, hopefully soon.
So that's a very interesting point, because many times, even in patients with a low CNS IPI, we are sometimes caught unaware. We have had n number of patients relapsing after 4 cycles, after end of treatment, coming back with a bad CNS relapse. So I think probably more sensitive techniques to look for occult disease in the CSF would be the way to go forward. And these patients can receive more intensive treatment. But having said that, in the high risk group of patients that you mentioned with the adrenal, testicular, or breast involvement, Would you consider treating them upfront with a dose-adjusted EPOCH-R? And is there any data to suggest that that is superior to R-CHOP in preventing a relapse?
I think these cases are so rare that we don't really have prospective data, or like the prospective studies, when they pull out these subgroups, they're not powered to actually give us a difference. And so we don't necessarily always escalate to dose adjusted EPOCH for testicular DLBCL or breast DLBCL. But we consider doing high-dose methotrexate prophylaxis along with R-CHOP. And that's because dose-adjusted EPOCH has intrathecal prophylaxis built in. And then we know from data that the high-dose methotrexate has better parenchymal penetration. And the relapses are generally in DLBCL, like we talked about, more parenchymal than leptomeningeal. And so I think my approach is, if we are worried about risk of CNS relapse and we want to do prophylaxis, I would still use R-CHOP with high-dose methotrexate rather than using EPOCH, unless there are other factors such as high-grade with MYC BCL2 rearrangements, which makes me choose EPOCH in that situation.
And is there any biological reason or pathogenesis why patients with an adrenal involvement or a breast involvement have a higher risk of, because we have very often wondered, testicular, yes, it's a sanctuary site, but what about the other sites? Why do these patients have a high risk of CNS involvement in the first place?
That's a great question, and I don't think I know the answer to that. I think the closest thing I can think of is the fact that just the behavior of the lymphoma with more extranodal disease tends to do that. And so it's not just having isolated adrenal involvement, but if you see, you don't usually see isolated adrenal involvement. You see that in the context of other extranodal sites of disease. So I don't know if it is the fact that that lymphoma tends to occupy more extranodal sites, or it is these specific organs, which leads to the CNS relapse. I don't have the answer to that. And then, of course, again, most of these are non-GCB subtype DLBCL as well, that have more extranodal disease and involvement of these sanctuary sites. So I don't have a clear answer to that.
But whenever we do have to assess for a CNS involvement, would you recommend, in addition to a CSF flow cytometry and MR spectroscopy also? Like you rightly mentioned, majority of the times it's the parenchymal involvement which is far more common. So like very often in our clinical practice, we do a CSF assessment, but many of us don't go and do an MRI even for patients with a high CNS IPI. So do you think at diagnosis, both these tests should be done?
I do tend to do both an MRI of the brain as well as CSF analysis, because CSF will only pick up if there is CSF involvement or leptomeningeal disease and not parenchymal. And I have diagnosed occult findings on the MRI that make me want to treat the patient as a secondary CNS lymphoma even when they're asymptomatic. So my standard practice is to do both an MRI brain and lumbar puncture with CSF flow cytometry. I don't do a MRI spine unless there is symptoms that are pointing to spine involvement, because that is less frequent. But certainly MRI is a part of my normal CNS staging.
And if my understanding is correct, you would consolidate all these patients with an autologous transplant, carmustine thiotepa. And
Correct.
if patients have an inadequate response, you would go ahead with a CAR T.
Correct. So of course they need to be in a complete remission to go to a thiotepa carmustine transplant. So there have been cases that I was thinking of presenting. Well, that was a primary CNS lymphoma. But if patients don't achieve adequate response to methotrexate or methotrexate refractory, then I generally treat them with a second line CNS directed regimen, such as like cytarabine, etoposide, or use some other CNS directed treatment to try and get them into a remission, because it is true for all autologous stem cell transplants. The better remission you are in before you do the transplant, the more likely of success and durable response. Versus if you take a refractory patient to an autologous stem cell transplant, the odds of having durable control are very, very low. So I guess it depends on the response. And sometimes if you don't have access to CAR T, it is okay to use a second CNS directed treatment that's not methotrexate based, using cytarabine, etoposide, or a thiotepa based regimen like Matrix, trying to get them into a remission.
So now we have two CAR T cell products approved in India for DLBCL as well as ALL. So in patients, let's say after 4 cycles, if they don't have, they are either stable disease or a partial response, would you still consider collecting the T cells for preparing a CAR T prior to going ahead with further treatment? So in other words, when would you consider label a patient refractory as early as 2 cycles, 4 cycles? And in these patients, when would you collect the T cells for a CAR T cell therapy?
And are we talking systemic or CNS?
Systemic with CNS involvement.
Systemic with CNS involvement. So I think the partial responses are challenging, right? Like, if they're having some response but not meeting a criteria for even a partial response after 3 cycles of treatment, then I think I worry that they're going to be refractory, or if they have just stable disease. But if they have like a near complete response with very little disease, then I am hopeful that more of the same treatment, to complete the 6 cycles is going to get them into a remission. So for patients who have an inadequate response or less than partial response, I would certainly move on to something else, and try to get them collected for CAR T, especially if they have refractory systemic disease. Because the challenge becomes with the thiotepa carmustine auto, sometimes I've seen systemic relapses, even though the CNS disease is controlled. So it is a fine line to navigate. So if you have less than partial response, I would certainly try to collect for CAR T if you have access to it, because that is clearly the better treatment compared to autologous stem cell transplant, in terms of refractory DLBCL based on all the phase 3 studies that we've seen. But for patients who don't have access to CAR T, and you think you want to try to get them to a thiotepa auto, then I guess trying a different regimen to achieve a better response. But I would certainly not continue the same regimen if I'm not seeing a good response up at 3 cycles or interim scanning.
On that note, very often we have patients who are tolerate lymphoma-based treatments like R-CHOP or methotrexate reasonably well, but they may not be fit enough for a transplant. So even if, let's say, a patient who is 58-year-old has comorbidities, DLBCL with a synchronous CNS involvement, achieves a CR after 6 cycles, not fit enough for a transplant, would you consider taking this patient for a CAR T cell therapy if they have access to it?
Not typically. I think in that case, you can, well, depends. So there is the transplant ineligible CAR T fit, and then there is the transplant and CAR T ineligible patient, right? So for patients who are chemosensitive achieve a CR, I mean, there is a small proportion who might remain in remission. I think in that case, maybe I will use an approach like we use in primary CNS lymphoma, where patients, when they're not fit, you either consider consolidating them with using radiation if you think that they can tolerate that and cognitive impairment is not going to be significant. That'll be a one and done scenario, or consider a maintenance program. So there's like methotrexate maintenance where you give it instead of every 2 weeks, every 4 weeks, and finish out a 1-year program of methotrexate maintenance to decrease the risk of relapse. So that may be my approach, or use like lenalidomide, because there's certainly data for lenalidomide maintenance in DLBCL systemic, right? But the concern is more toxicities and increased complications, especially in the older patient. And when you have CNS involvement along with systemic involvement, I think lenalidomide is an agent that has CNS penetration. And so considering it for maintenance in those circumstances might be an approach I take rather than taking patients through CAR T.
So you would probably reserve CAR T for a relapse setting or at the first
Correct.
relapse, even in these patients.
Yeah, correct.
And very interesting point. But like the second subset that you mentioned, who are transplant ineligible and CAR T ineligible, even if they achieve a CR, would you consider putting all these patients on some kind of a maintenance? And you also always mention the lenalidomide and the methotrexate maintenance. But can BTK inhibitors also be used as a maintenance strategy in these patients? And if so, for how long would you continue the maintenance and what would be the dosing?
Yeah. So I have used BTK inhibitors as maintenance. There is not data to support a maintenance strategy, but if you have access to it and can do it, I don't think it is wrong. The duration is very challenging because I had a patient who had CNS relapse, CD5 positive DLBCL, got him through CAR-T. We couldn't really measure his disease in the CNS because he had more like nerve involvement. So we didn't quite know whether he was in a CR or not, and his symptoms were persistent. So we put him on BTK maintenance. I sent him back to his local oncologist who questioned how long the BTK maintenance should continue. And so he stayed in remission for 2 years while he was on the BTK maintenance, after which point the oncologist was like, well, we don't know whether the BTK is doing anything, so let's try and stop it. And he stopped, and within 3 months had another relapse. So, BTK, I think of more as like static drugs than in the sense they only control and don't cure BTK inhibitors the way they are. And once you take the foot off the brakes, the disease relapses. So I guess it's very hard to define a duration for maintenance therapy with BTK inhibitors. And so if the patient can do it, I would keep them indefinitely on BTK inhibitors in that case, just given my anecdotal experience.
I mean, that's a very interesting point because these are drugs which are affordable and which all our patients have access to. So many a times when expensive treatments like CAR-T may not be possible, or if patients are not fit for our transplant, then probably these might be good options in the Indian setting. A very
I
practical
agree.
question. So once you collect the T cells for these patients, what is your interim strategy while the CAR T cell is being prepared? Because we don't want to give too much of treatment and cause toxicity. At the same time, we would want to keep the disease where it is. So as a bridging treatment, what is your practice? What are the medicines that you use regularly?
Yeah. So if it is an isolated CNS relapse, I have used radiation if the patient has significant symptoms, but otherwise I avoid radiation, and then I've used BTK inhibitors as a bridge. They work fairly quickly even if you have just a month between CAR-T, like the first case we discussed, she got BTK bridging to CAR-T, and that was able to control her disease to some degree. For patients who have systemic and CNS disease, I think it is even more challenging because things like lenalidomide are slow to work. Like if I was thinking like tafasitamab, lenalidomide is an option. And so I've tried to use like RMBVP, which has some etoposide carmustine in it. So trying to figure out a regimen. I might use matrix, although it is very myelosuppressive, and so it's a challenge sometimes when you're trying to give just one cycle to a patient. But yes, I think that is a very challenging situation. Or using something like hyper-CVAD Part B, where you have rituximab and cytarabine, just one cycle to get them to the CAR-T are options.
And in patients who have a CSF involvement, what is your typical treatment protocol as far as the intrathecal injections are concerned? How often do you give it, and how do you maintain them once they achieve a CSF negative status?
Yeah. So our usual protocol is to do intrathecal methotrexate, cytarabine, hydrocortisone, so triple therapy twice a week till they clear the CSF. So once the CSF is cleared, then we go down to once weekly, and we can sometimes, instead of doing triple therapy, just drop one drug and do just intrathecal methotrexate or intrathecal cytarabine. And then, depending on what the end goal is, there's usually some sort of consolidation after that. So till that point, we maintain with weekly intrathecal injections in most circumstances.
There are a couple of questions in the chat box. Dr. Rohan Haldar has a question. Do you have any experience with the Marietta approach in young, fit patients with concurrent CNS lymphoma? And have you faced problems with stem cell collection after matrix chemotherapy?
Now, that's a great question. And I have not used this Marietta approach, even though that obviously has the most data to support it. So I don't know that I have an answer in terms of from my experience. I can look at the paper. I know they did report with there were issues with stem cell collection after the matrix regimen. And I don't know whether they collected immediately, like as soon as they knew that the patient was responding, or they completed the full 6 cycles. Let me just look at that schema that I shared with you guys. It doesn't say on the schema. So I'm sure the paper has that information, but I did not necessarily look at it.
Dr. Sumit Mirk has a question. Do you use intrathecals in your routine practice for prophylaxis in high-risk cases or treatment of secondary CNS lymphoma? If yes, which drugs apart from methotrexate in it?
Yeah. So, like I said, my preference is to use high-dose methotrexate systemically for prophylaxis rather than intrathecal, but sometimes patients can't tolerate it, have poor renal function, or you just prefer the ease of using intrathecal in those cases. My preference is always to use intrathecal methotrexate, but there have been patients with some sort of toxicity or reaction to methotrexate, in which case cytarabine is the other drug that we use. But apart from methotrexate and cytarabine, I don't think we use any other agents.
After we have started doing ctDNA for few of our patients, we have been contemplating how to use it as a monitoring tool in patients who achieve a CR after R-CHOP or 6 cycles of treatment. So as part of clinical trials or in your experience, what is the best way to use ctDNA post-CR in these patients? And let's say the ctDNA comes up or there is a significant increase. Do you really act upon it at this present moment in your clinical practice?
So in my clinical practice, we are currently not using ctDNA, but I know that the NCCN guidelines just updated in this last week and now includes ctDNA testing for patients who have an end of treatment positive PET scan. The way I think about ctDNA, and also the caveat I will say with the data that we've seen so far with ctDNA is, even though you may have a positive ctDNA at the end of treatment, sometimes at the 3-month mark that actually becomes negative or decreases. So I think of it more as not a one-time test, but more as a trend that will give us an idea which way this disease is going or behaving. I think it can be useful in cases where the PET is positive and it is a hard to biopsy situation where you don't know for sure whether that is relapsed refractory lymphoma or not. And then if you have a positive ctDNA, I would act on it, because then I have a positive PET scan and positive ctDNA. That's adequate information to say that this is a primary refractory disease, and I would go ahead to second line treatment. But in a PET negative patient, if I have a positive ctDNA, I probably will only use it for monitoring. And if there is a persistent significant uptrend, then maybe. So because with the negative PET scan, generally I stop scanning patients. I don't repeat the scan except at like the 1-year mark, just to make sure they're in remission. And most of the time I'm doing CT scans. Versus if I do have a positive ctDNA with a negative PET scan, that might be a patient I'm going to monitor every 3 months with scans, and I might subject them to a PET scan because I have a high suspicion of relapse, particularly if the ctDNA is trending up. So I think we're still learning how to use ctDNA in practice, and maybe if I come back in a year, we'll have more information to discuss from experience. But at the moment, we're not using it, and I think I would be very cautious about making treatment decisions. Except, like I said, positive PET, positive ctDNA might be a situation where I believe the result and make a treatment decision based on it.
I would like to discuss a couple of difficult cases that we have encountered in the last few months. So we have a 21-year-old male patient, had severe aplastic anemia in 2017,
Mhm.
treated with an allogeneic stem cell transplant, developed chronic GVHD, multiple complications. 7 years later, patient had generalized lymphadenopathy, weight loss, high-grade fever. Biopsy showed Hodgkin's lymphoma. Biopsy confirmed.
Mhm.
Treated with ABVD, showed a fantastic response after 4 cycles. Completed 6 cycles, and within 2 to 3 months, he developed new onset symptoms. Repeat PET showed extensive disease. A biopsy was done, which revealed a diagnosis of DLBCL,
Oh no.
GCB type. And by then, patient was not really fit for any intensive treatment. He had cytopenias, high-grade fever, ferritin of 40-50,000, soluble CD25 of 25-30,000, associated lymphoma-related HLH. Started him on steroids, improved symptomatically, gave him a cycle of RCVP. In second cycle, we treated him with RGDP as a salvage regimen.
Mhm.
And Post second cycle, currently patient is having a partial response, almost 70-80% reduction in his lymph nodes. So the ferritin has come down from 20-30,000 to 5,000, and cytopenias are still persistent. So in this scenario, do you think he did not have any CNS involvement? This was a DLBCL post transplant after 2 cycles response, and patient had a stormy course, had candidemia, went into septic shock, currently not unfit for any treatment as such, except maybe a low grade therapy. So in him, I have a couple of questions. One is, since he has achieved a response, do you think he would be a candidate for a CAR T cell therapy? Number one. And number two, in the background of a HLH, lymphoma associated HLH, what are the precautions you would take? And can you collect stem cells from these T cells from these patients for CAR T manufacturing?
Great questions and very tough case. So the few thoughts that come to mind when I've seen this concurrent, multiple histologies where you had a Hodgkin and now you have a DLBCL. In terms of response, has he had a scan, and are all sites of disease responding at this point?
Yes.
Yes, okay.
Sites
Because
are-
sometimes you worry that they could have concurrent Hodgkin lymphoma that's, relapsed, hiding in that PET scan that has all the DLBCL as well. So in these circumstances, I mean, I guess if you are worried that his Hodgkin could also come back, then maybe an auto transplant is a better approach than CAR T cell therapy, because that would be killing two birds with one stone. The few other thoughts I had as I was listening to your case is, generally for HLH, did he have EBV viremia, or was this EBV related?
No, he did not have EBV viremia, but forgot to mention he does EBV related. Iberish was positive on the biopsy, but
On the
however, he
biopsy,
did
but
not
not
have EBV viremia.
PCR. Okay. So for etoposide, the treatment protocol, for HLH, the treatment protocols include etoposide. And so as you were speaking, and since he just received anthracycline with his ABVD, I may have chosen like our COEP for treating him, so that he would be getting the benefit of etoposide, as well as curative intent treatment for his DLBCL. And in that case, I may not consider an autologous stem cell transplant necessarily, because clearly if the HLH is secondary to the lymphoma and we're treating the lymphoma with curative intent, I might make the argument that if I can get him through 6 cycles of a definitive treatment for his DLBCL, such as RCOEP or our GCVP, which are alternatives for like anthracycline exposed patients, then I may not consider consolidation in the frontline setting. So we don't always consolidate all HLH patients with an autologous stem cell transplant, because sometimes just curing their lymphoma with chemotherapy is adequate to prevent relapse of the HLH. So that's what I was thinking. I wouldn't always consider consolidation in this patient, but of course, if he has an inadequate response or his HLH starts to act up, then I would probably consider more an autologous stem cell transplant than CAR T. If he has refractory DLBCL, then I guess CAR T would be the way to go. And I am honestly not sure that we have encountered this, or if there is data about what T cell collection or CAR T manufacturing would look like in the setting of active HLH. But I mean, the only thing to do is try and see what happens.
So he's not fit for an autologous transplant, which is why we were considering possibility of a CAR T, and neither would he be fit for any intensive treatment. Even with GDP, he had really bad cytopenias, went to the ICU, had
Okay, so
candidemia.
etoposide would be hard too. Yeah.
So we were just wondering whether CAR T would be an option for him.
It could be an option, or you could just try to see if we achieve a durable response and reserve CAR T for the time of relapse. I don't think I've used CAR T in any circumstance where the patient, hasn't tried curative intent treatment and failed that first. So I know he's had a pretty bad circumstance with everything happening, but I worry, and the things I worry about is like if we do CAR T cell therapy and then his Hodgkin lymphoma relapses, then you're again in a tough space. So it's more important for this gentleman to recover immunologically, right? Given all the lymphomas that he's developed post allogeneic stem cell transplant, than to try to consolidate the response that he has achieved right now.
Right. I think Dr. Anusha has also joined us. So Dr. Anusha in our group is a clinical lead for the lymphoma program at our center, and she sees all our lymphoma patients. I'm sure she has a few interesting scenarios to discuss and probably a couple of comments also. So Dr. Anusha, are you there?
Hi, yeah, good evening. Can you hear me?
Yeah, please
Yes,
go
I can
ahead.
hear you.
Yeah.
Can I just also say I can only give 2 more minutes of my time. I do have to head to work. So yeah, I would love to hear what you have to say.
Oh, that's okay. So just adding to Dr. Rohan's question, when do you do the stem cell apheresis? If you're giving M-R-CHOP, you're able to go through all 6 cycles and have no difficulty in collecting the cells, or because we get nervous when we add the Marietta and then we tend to do it in between. So
Yeah, I like I said, I don't have experience with Marietta. It is more myelosuppressive. It does have other agents like the thiotepa and the ifosfamide, carboplatin. So I do think it is reasonable in that case when you know you're going to an auto transplant to collect up front. With MR-CHOP, we've had no issues collecting after 6 cycles.
okay. In patients who have a Richter's to DLBCL from, let's say, a relapsed refractory follicular, what is the
Mhm.
patient subgroup where you would definitely do a CNS assessment? Apart from obvious symptoms, is there anything other, all Richter's patients or any particular patients that you would do a CNS assessment for sure?
I think patients who have high-grade B-cell lymphoma with MYC-BCL2 gene rearrangements, and we've seen that sometimes with transformation, that they transform into a high-grade lymphoma and not just DLBCL. In those cases, I would do an assessment. But otherwise, in the lack of, if there are no symptoms, we don't typically assess the CNS.
Okay. A patient has high CNS IPI baseline, plus or minus adding a prophylactic CNS treatment. At follow up, is your follow up any CNS directed investigations done? Other, of course, apart from clinical assessment.
Yeah, we do MRI. So I feel like I scan my CNS patients more than I scan my DLBCL. So in DLBCL frontline, if they've achieved a CR, then I don't do scans for monitoring because there's evidence to say that it doesn't necessarily pick up relapse. So I scan them just at the 1 year mark just to make sure in case they're relapsing asymptomatically, I can get them CAR-T if that's the direction they need to go in. But for my patients with primary or secondary CNS involvement, I do tend to scan them every 3 months with MRIs, at least for the first 2 years, to make sure that they are not relapsing. And so I can't always rely, and it's always sometimes hard to rely on clinical symptoms because they have some residual deficits or things from their previous CNS active lymphoma. And so it's sometimes very hard to assess just based on clinical history. And so that is one place I do use MRIs every 3 months.
Oh, I meant like without a frank CNS disease, with just a high CNS IP.
Oh no! With a high CNS IP, I don't. No, I don't monitor them unless they have CNS symptoms.
Okay, final question, then we'll let you go.
Okay.
We somehow find it very difficult to convince our patients for a brain biopsy. It is
Mm.
a invasive procedure, and we do know the understand the value of it. What are the situations where you'd be very comfortable in not doing it?
The only situations I'm comfortable in not doing it is if they have a positive CSF that confirms lymphoma, or they have systemic disease concurrently that I can biopsy and confirm lymphoma. Any other situation makes me very uncomfortable. And then sometimes you I mean, those situations do happen, and in those cases, sometimes you do things like give a trial of steroids and see if they've responded. And if they respond, then you say, oh, this is most likely lymphoma. If they don't respond, then you say we need the biopsy anyways. So I guess that is the very challenging situation where there's nothing else to biopsy or no other histologic confirmation. But wherever possible, I think we try to push our neurosurgeons and patients to get the biopsy because we've been surprised so many times that we don't want to be treating the wrong thing.
Any CSF molecular markers? Would you rely on them? No, only a
Um,
flow.
I think flow is the most important. We actually are dealing with a case right now, which is like a PTLD after solid organ transplant, where the flow is negative. The only thing that's positive is EBV in the CSF, and it is in a location where we can't biopsy. And so it's very hard to call it CNS lymphoma. But at the same time, that patient improved with just reduction in immunosuppression. So they're very cautious and calling it CNS PTLD at this point. So I think those are very challenging situations.
Okay, thank you
I
so much.
am going to have to take your leave. Thank you so much
Thank you,
for
Dr.
this great
Priyanka. We
discussion.
have taken up a lot of time. Thank you so much for sparing your time on a Friday morning and enlightening us on the management of DLBCL with CNS disease. You answered all our questions very patiently, and I'm very sure this webinar provides a lot of clarity in management of this difficult group of patients. Thank you once again for joining us. And I thank each and everyone who has joined us from different countries across the world for this webinar. We'll again catch up next month with a clinical based innovations in hematology webinar. Thank you, everyone.
Thank you. Take care.
And I also thank MCure Pharmaceuticals for providing this platform for conducting the webinar. And thank each and every one of you who has spared their Friday evening for joining us for